The Lincoln Spring Sales event is on now, and there's never been a better time to experience the feeling of driving a Lincoln. Pictures, sunlight through the available panoramic vista roof, music, weather, and maps on the 48-inch panoramic display, and a drive so smooth that inspiration rides up front. Stepping out better than you got in. That's the Lincoln feeling. Get behind the wheel of the 2026 Lincoln Nautilus SUV and discover exceptional offers only at your local Lincoln retailer.
This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. Don't forget, this podcast offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME will be in the show notes. This week, we are going to be discussing managing alcohol withdrawal over telemedicine. So how are you doing, John?
I'm exhausted tonight, Sonya. I got to tell you that. I'm rounding in the hospital this week.
Oh my gosh.
It's the middle of flu season and, low vaccination uptake rate, bad flu season makes a bad combination.
It is. And I, as someone who admitted like 12 people to the hospital for flu over the last week, I really apologize.
Yeah, and I feel like it brings back like PTSD, just wearing all the contact precautions from room to room. I feel like it just slows you down so much. And then you're like in this sweaty, almost like, it's like a wrestling garb where you're like trying to sweat out the water while you're talking to them. And it just makes you like uncomfortable all day. But only one more day.
Only one more day. Flu season, what, another month or two?
I don't know. We'll see.
Oh my gosh. Well,
how about you?
John, I'm doing fine. I sent all these people to the hospital, and then I had to do hospital follow-ups on all the people who wanted to know why they still felt terrible, even though they'd been released from the hospital. That's pretty much the story of this week. And I think the hospital kicked them all out because it was too full. So, like, once your O2 sat, like, crossed the 92% threshold, you were out.
Yeah. Yeah, it's interesting. They certainly have moved a lot of that care out of the hospital.
Yeah. Yeah, I'm glad. I mean, it's nicer to be home, but nope, I'm happy to be doing the podcast, though. So, John, anything you wanted to talk about in addiction medicine news this week?
Yeah, I think the big announcement was the almost $2 billion cut from mental health and addiction treatment programs that just occurred. Did you read about that?
Sure did. I mean, it's January 14th, and the letters went out the evening of January 13th. Who knows when this episode will air, but yeah, $2 billion. It's about 25% of SAMHSA's budget, I think. Just flamethrower, wiped out with no notice and no plans for transition and no acknowledgement of what was chosen, why. So extremely upsetting.
Yeah, it looks like some of the key programs were kind of funding for opioid treatment directly, but then also kind of our more vulnerable populations, kind of like, addiction services for people experiencing homelessness, post-incarceration support, and behavioral health, which is ironic because I feel like, I might get a nasty gram about this, but I feel like every time we have a mass shooting in this country, everyone says we need more. It's not guns, it's behavioral health support. And now the group that's saying that is saying, screw your behavioral health support.
What's interesting to me is not only the sort of destruction of the treatment infrastructure, as if we don't need drug treatment, but how kind of pro-drug the Trump administration has been. They've been pardoning drug kingpins, some of these biggest drug kingpins that, the federal government worked to prosecute have all been pardoned and released. Trump is making cannabis more available. He started the process of rescheduling it from Schedule 1 to Schedule 3. They removed recommendations about the dangers of alcohol from the new dietary guidelines. So and Dr. Oz was quoted in a press conference I watched online saying that alcohol is a social lubricant. It's important as a social lubricant. So we shouldn't, say exactly how much you should drink. In general, it just seems like the administration's really moving to make drug use more common, more accessible, and then less easy to treat.
Yeah. Yeah, so it's kind of disheartening. Although I think we talked a little bit before this. I think my biggest bugaboo with this a little bit too is I think that addiction treatment is such an important part of healthcare, right? This people with untreated substance use disorder, they really disproportionately utilize our healthcare system in less than ideal ways. And so treatment's really part of their care. And I don't understand how we can have such a huge need in our community and in our country. And yet, just general reimbursement doesn't cover the services needed here, right? I think that, like, no one's saying that we need a grant for more cardiac catheterizations or epidural steroid injections. Those are reimbursed to a degree that they're cost sustainable. I don't understand why we can't have a reimbursement program that actually allows these to at least be cost neutral for organizations to offer this. Like, why do health systems that do this operate in the red and need these grants to just break even?
Right. Well, I mean, I think it has to do with the fact that our health system is fragmented and the incentives aren't aligned. The people getting cardiac caths are covered by one set of insurance, and the people getting addiction treatment are covered by a whole different set. They're a different demographic, and those two don't communicate. We don't have a single payer. And so, even though it costs our society more if we don't treat addiction, for any one individual person paying for the treatment, it doesn't cost them more personally if the addiction doesn't get treated.
Yeah, I don't know. I'd argue both are predominantly state payers, right? I think this idea that we don't have a single payer system, we have a predominant payer system.
Yeah, but it's still fragmented.
Yeah. Anyway, kind of disheartening. I guess we'll
It
have to
is.
see.
Yeah.
And the problem too with cuts like this, right? It's like just like some of these health overhauls, is like you're not going to see the effect of this. It's going to be delayed like 12
Mhm.
to, 36, 48 months. So it's probably not going to, people are going to act like it doesn't make a big difference because you're not going to see an immediate change tomorrow, but you will see an immediate change in the coming years, or
Right.
a semi-immediate change.
Well, and as you cut and dismantle these programs, you can't just get them back overnight. You know,
Yeah.
it took years to build up these programs, and it'll take years to build them up again in the future if we need them. I guess it's um, most disheartening because we actually have been making really good progress against overdose. We finally gotten a handle on overdose deaths, and now we're suddenly dismantling the programs that really made a difference. And the Trump administration is specifically against any harm reduction programs, focusing just on, like, punishment and treating fentanyl as a weapon of mass destruction, whatever that means.
Yeah.
I prescribed fentanyl on Monday. I don't know what that means for my own, weapon of mass destruction position. First
Well,
weapon of mass destruction I've ever prescribed.
well, I don't know.
We'll have to
We'll have
see.
to see. Hopefully the future's brighter than this one announcement.
Yeah, I mean, it's the only hope I have is that as announcements get made and proclamations are released, but how it plays out on the ground is a question still. All these proclamations are done with so little planning. It's hard to know how it will actually play out.
Yeah. Yeah.
So,
Like the
hmm?
Uh, so like the Ebola funding that was cut and then reinstated very, very quickly.
Yeah, exactly.
All right.
Oh my
Yeah.
gosh. So, yeah, you want to talk about this article, John, talking about treating alcohol withdrawal?
Yeah. So this is kind of something a little different. It's from the Journal of Addiction Medicine. It's called Symptom-Triggered Alcohol Withdrawal Management Delivered Over Telemedicine. So I think I always like one thing that I really like in healthcare, and like I do have a pseudo administrative job, but I like looking at things to do things differently. Like I think a lot of times we have kind of this classic care pathway where it's like you must schedule a visit, we must see you in person, you must go to the hospital for this. And I kind of like to see efforts to disrupt that to kind of meet people where they're at a little bit better. So I thought this sounds like a really cool idea. So, a little bit of background: alcohol use is a major global cause of death and disability. Only 7.9% of Americans with past year alcohol use disorder receive any treatment. That was from 2023. There's a significant rural urban disparity, with rural residents receiving less outpatient treatment. They rely more on ED care, and they have a higher 1 year alcohol related mortality than people who live in a more urban setting. Telemedicine improves access and has demonstrated effectiveness for delivering alcohol use disorder, psychotherapy, and brief interventions with similar retention and satisfaction rates to usual care. Withdrawal management is a critical first step in moderate to severe alcohol use disorder treatment, and it really is not currently utilized via telemedicine, so it's underdeveloped. Untreated withdrawal can be life threatening. Benzodiazepines are first line treatment for alcohol withdrawal, and kind of standard of care at this point has really become a symptoms triggered approach for treating alcohol withdrawal. Um, and most people listening here probably know what that is, but we used to do like just scheduled benzodiazepine tapers. And what they've done over the years is they've done data showing that symptom triggers where we use kind of CAL scoring or kind of withdrawal assessment, MINDS or CAL scoring, we end up using less benzodiazepines, and the withdrawal period tends to be shorter with less complications. So we've gone from just these kind of fixed tapers to calculated triggers based upon like what a patient's actually experiencing.
Yeah, I remember when we made that change. It used to be only one way, and then we switched everything to symptom triggered.
Yeah, I'm a huge fan of it. I think it's really worked well. Now it works for most patients, right? So like, clinical discretion still sometimes requires the use of a fixed taper, but I think it works well in the majority of cases. So the idea that this kind of possibility of a virtual symptom triggered withdrawal model could expand access, especially to our more rural environments, is something that could be very promising. So the clinical question here is symptom triggered alcohol withdrawal management delivered via telemedicine feasible, safe, and acceptable for adults with alcohol use disorder who are at risk of withdrawal? A little bit about this study. So this is a single arm, open label, prospective feasibility trial. And it was evaluating 3 days of telemedicine delivered symptom triggered alcohol withdrawal in 30 adults with alcohol use disorder and prior withdrawal history. They were recruited from CAMH in Toronto, and it was really just to assess the safety, retention, need for higher level of care, satisfaction, and 30-day return to alcohol use. So this is more of just kind of like this isn't an RCT. It's basically a trial seen if this is safe to kind of build upon.
Yeah, you would even call it just like a case series. We did this for a small set of patients, saw what happened.
Yeah. The participants, so there's 30 adults with alcohol use disorder, all of which had a previous history of withdrawal. So this is a more severe subgroup. They were recruited via clinician referral from the Center of Addiction and Mental Health, outpatient clinics in Toronto. So basically, they were still assessed by a clinician to determine whether or not they'd be a good candidate for this. All participants were greater than or equal to age 18, so adults. They were actively drinking. They previously met DSM-5 criteria for alcohol withdrawal. They were able to complete 3 days of telemedicine-based withdrawal management, and they all had to have stable housing. Exclusion criteria were people with a history of complicated withdrawal, so seizures or DTs or hallucinosis. If you had another substance use, so kind of opioid use, sedative use, a positive urine drug screen, something that complicated the clinical picture, you were excluded from being eligible for this. If there was contraindications to the use of diazepam, if you were pregnant, or if you had unstable housing. So that was the inclusion and exclusion criteria. So a little bit about the protocol that they used. So participants received a very limited supply of diazepam, usually 8 10-milligram tablets, and they received that before withdrawal. They asked participants to remove all alcohol from their house prior to starting this process. Additional medication could be prescribed via fax or phone if the supply ran out and that was deemed appropriate. So it wasn't like you hit the 8 pills and you were done. You could still extend it if need be. You had daily check-ins via this program called WebEx at 9 a.m. where they assessed using telemedicine adapted CWA revised. They basically did a revised CWA with the information you could get from telemedicine. If you had a score greater than or equal to 10, you got 10 to 20 milligrams of diazepam and you were reassessed in an hour. If your score is less than 10, you were reassessed every 1 to 4 hours based upon clinician discretion. There was no at-home vital sign monitoring, so there was no kind of blood pressure cuffs or anything like that, and that was because of the scalability of the project. The telemedicine sessions lasted approximately 5 to 10 minutes, and they were extended as needed. Every day, in addition to the clinician involvement, a physician reviewed participants, and they would talk about could you use the as-needed overnight diazepam, and they would record that the following day. The protocol was repeated over 3 days, and withdrawal was considered complete if you had 3 consecutive CWA-ARs scores that were less than 10. They could extend beyond day 3 to up to day 5 if need be, but no longer than 5 days of treatment in this protocol. The primary outcomes was retention and treatment. So it's the percentage of participants completing all 3 days of remote withdrawal management. They wanted to see if there was a transfer to a higher level of care. So percentage of patients that needed to go to the emergency room, needed intensive monitoring, or had acute intoxication. They looked at non-retention, so people that returned to alcohol use or were unreachable. They did a feasibility benchmark of at least 70% retention to the program and less than a 20% transfer rate to a higher level of care. Secondary outcomes were patient satisfaction, looking at a client satisfaction questionnaire. They did a telemedicine satisfaction questionnaire. And they looked at clinical metrics like mean peak withdrawal severity score by day, diazepam dose per day, percent of participants requiring benzodiazepine treatment, duration of active withdrawal treatment. They did adverse effect data collection, like side effects of diazepam, like drowsiness, falls, and withdrawal complications like seizures or hallucinosis. In terms of the alcohol use outcome, they also looked at proportion return to any alcohol use, those to be a timeline follow back. They did change in alcohol use before and after treatment. And they actually did have one objective measure here. They did an ethyl glucuride level to confirm abstinence for participants that completed the in-person follow-up. So I like it when they kind of par that together. They did kind of a binomial testing analysis of the primary outcomes. They did descriptive statistics for secondary outcomes. Alcohol use disorder return was kind of evaluated via Kaplan-Meier curve. And they did pre and post drinking was compared using kind of paired t-tests. So that was kind of the statistical analysis component. So what do you think of the trial so far?
I think it's good. I mean, it's a great question. I'm really interested to see if it works. I do ambulatory alcohol withdrawal. If someone has a serious alcohol problem, if they struggle to quit drinking because of the withdrawal, but they don't need to be admitted to a detox, I do it. But my protocol that I've used has been more of a fixed, not symptom triggered. I've said day one, I might use diazepam and say 50 milligrams on day one, 40 on day two, 30 on day three. I don't remember the exact numbers in my protocol, but it's not symptom triggered. I haven't had this thing where I would call people and do like a home CWA scale every day to dose the home medications. So I'm interested to see how it worked.
Yeah.
So if you do ambulatory alcohol withdrawal, before reading this trial, did you do that? And what kind of protocol did you use?
I'll be honest with you. I am a little more gun shy about this. And I'll be honest, based on bias of personal experience, I think like in residency, I had a patient that we did an outpatient alcohol withdrawal on, and they went home and drank, and they actually had an arrest and had a very bad outcome. And so I feel really gun shy doing that. And I know it's an N of one, but you just feel bad when you're involved with that, right?
Yeah.
So most of the time I calculate a pause score and I determine whether or not that, they're safe for inpatient or outpatient. And based upon that, I kind of talk about options. I really like gabapentin because it's kind of useful for both, but I'm kind of somewhat hesitant giving people a handful of Valium, not knowing that I have good follow-up on them in the coming days. Like if I could check in on them daily, that'd be one thing. I just haven't had that bandwidth.
Yeah, understood.
Yeah. So, is this trial valid? The trial was funded by the Ontario Ministry of Health and Long-Term Care and the Canadian Institute of Health Research, so no industry funding there. Some of the authors had like weak financial ties to Indivior, Canopy Growth Corporation, and Bioproject. I would consider these very weak industry ties in this clinical scenario, especially since the only medication is diazepam, and that's generic. It's a small prospective study of 30 adults with alcohol use disorder. So, like I said, it's more of a cohort study or a case series study, more so than anything else. So, not a RCT. And this is really just to kind of determine feasibility of a protocol like this. There was no control group. I do think it would have been interesting to see a comparison of an in-person versus telehealth outcome. So, like same resources, same provider administration. Was there a difference in actually touching the patient, them coming into the office? That would have been interesting to see, especially when they're looking at more long-term outcomes for the secondary outcomes. So some of them were not directly related to a withdrawal period. I love how this study really excelled at linking patients to gold standard treatment. So, there is data that people that are addiction medicine specialists, they kind of have better outcomes than kind of general practitioners for kind of standard substance use treatment. I'm sure that while a general practitioner can definitely do that, and they should, having access to a true specialist is kind of a very unique thing. Not everyone has that access. They had remote behavioral health resources. They had high medication for alcohol use disorder uptake. So there was a lot of comfort level in prescribing those. So because of that, you kind of like participants in this, they really had access to like the whole shebang in treatment. So I don't think, well, I think this is like awesome they could do this. I think that maybe this isn't representative if you were to have like a real life or real world service of this for the average person. Just like a food for thought. I thought it was interesting the use of diazepam over lorazepam or oxazepam, especially since this group probably has underlying liver disease to some degree. Long half life, hepatic clearance. It's kind of interesting. Most of the symptom-triggered alcohol withdrawal order sets I've seen in the past have kind of used a more shorter acting benzodiazepine than diazepam, but I don't think that's a concern. Just kind of an interesting thing to note.
Well, I would think on those in those programs that are symptom triggered, they're in the hospital, so you have a nurse that'll like do your score every 6 hours or every 4 hours or whatever. This is sort of once a day, right?
No, they're checking in on you throughout the day in this protocol.
How many
So
times
is
a
there
day do they check in with you? I think I missed that.
No, so basically, if you kind of look at the protocol,
Right.
they
Oh,
were
reassess in 1 hour and then at 1 to 4 hours. Okay.
yeah.
Yeah.
So they were pretty on top of it. This wasn't like, hey, do your morning check-in, see you tomorrow. They were really managing these patients, which is really cool.
Hmm.
The study population, they were higher risk, but they weren't the highest risk, right? So, they did have everyone had a history of alcohol withdrawal, but not kind of the most concerning alcohol withdrawal categories like seizures or DTs or hallucinations or hallucinosis. So, I think that there's a selection bias there. Although I would imagine if this type of a program were to be available in real life, that we would use a selection bias there as well. Still, so I think that's very reasonable. What about you? Any kind of concerns regarding validity here?
No, I mean, I think with the acknowledgement that it's more like a case series or just a small prospective study, um, it would be great if it were comparing to something else, but I don't even know what like, there's a lot about it that's new. It's the telemedicine, it's the symptom trigger protocol, it's the frequent follow-ups. The whole protocol seems new. So, it's just really to see if it works, and I guess in the future, you could do a study comparing it to some other protocol that was different along one of these variables.
Yeah. So a little bit about the results. The demographics, those 30 actively drinking adults, they all met severe alcohol use disorder DSM-5 criteria. It was basically a mean age of 44. It was a bunch of white dudes, 60 to 66%. Most were single, so 60%. Baseline alcohol use was pretty high, so 10.4 drinks per day for men, 6.3 drinks per day for women that were in the study. In terms of the primary outcome, it very interesting and positive results here. So in terms of retention, 28 out of 30 completed it. So that's 93.3% retention. And that means they completed all 3 days of the withdrawal management. So that was like way beyond that benchmark of 70%. So huge completion rate. That's excellent. In fact, I would argue that might be better than people that start an inpatient symptom triggered alcohol withdrawal that I've seen at the hospital. Um, in terms of the non-retained participants, one relapsed. They basically relapsed on day one, the two patients. So they kind of like just immediately went to drinking and kind of dropped out of the protocol. In terms of transfer to a higher level of care, no patient was transferred to a higher level of care. So again, they had a benchmark of 20%, 0%. So that was highly statistically significant. No episodes of seizures, delirium, hallucinosis, and there was no ED visit. So that's awesome, right? So primary outcomes, very interesting and very positive here. In terms of secondary outcomes, in terms of one kind of withdrawal management and medication, 90% of participants required some degree of diazepam. So that means 10% kind of got away without it. Median diazepam dose on day one was 30 milligrams. Day two was 20 milligrams. Day three was 10 milligrams. CWA score by day kind of peaked at 12.1 average on day one, 9.4 on day two, 6.6 on day three. So it's kind of interesting. It was really kind of that first 24 hours where they were kind of hitting that kind of score greater than 10 that they were using as kind of a sign to kind of intensify treatment. The average daily check-ins per day. So this is interesting. How many times did the clinicians check in on these participants at home? 5.9 times per day on day 1, 5.1 on day 2, 4.3 on day 3. So that's a pretty high check-in date by your clinical team or ratio there. The average duration of treatment was 2.4 days for participants in this to complete their detox. In terms of satisfaction, highly satisfying. So a score out of 32 for the client satisfaction questionnaire, it scored a 30.9 out of 32. In terms of the telemedicine satisfaction questionnaire, it was a 45.1 out of 48. So a high degree of satisfaction among participants of this. In terms of post-withdrawal treatment engagement, 90% received alcohol use disorder pharmacotherapy, 83.3% received greater than or equal to 1 psychotherapy sessions, with an average psychotherapy sessions of 3.4. So kind of pretty good overall. That's much higher than any transition I've seen from inpatient treatment with alcohol use disorder to these medications or therapy sessions. I thought it was interesting to look at alcohol use outcomes. And the only reason I thought this is an interesting thing to look at is because I've not seen a ton of data that kind of withdrawal management really, you know, is a treatment for alcohol use disorder, right? It's normally kind of a bridge to something else. So I think it's an interesting outcome. Maybe it's more a surrogate marker for linkage to care for other services. But what they showed was absence at 30 days was 56.7%. So 17 out of 30 were not drinking. And that was kind of confirmed via the ethylglucuronide testing. So that was kind of very positive. In terms of the relapse pattern, 13 total patients relapsed. 70% of them relapsed within the first 10 days. So it's really that first kind of week and a half that you're out of kind of treatment where your kind of highest risk is. And then among the relapsers, actually, even when they did relapse, their drinks per day decreased from a mean of 8.3 to 3.9. So they did have a statistically significant lower drinking rate when they did relapse.
Well, I mean, it's amazing data. I think probably because such a high percentage received some kind of pharmacotherapy for alcohol use disorder. They got, like you said, the gold standard treatment. Um, that's why abstinence rates were higher as opposed to just putting people through a 5-day detox and then sending them back to right where they started.
Yeah, you could, I mean, that's definitely part of it, right? I do think, though, that there's something about the whole package, though, right? Because, when you look at those absence rates, like almost a 60% absence rate at day 30, that's much higher than an absence rate for any trial regarding kind of our gold standard medications like naltrexone or acamprosate, right? So I think I think that's part of it, but I think I wouldn't diminish just like I think keeping people in the comfort of their own home. I think that individualizing this approach to a patient, I think it's somewhat stigmatizing to walk into an office or a hospital with this type of condition. So I think it really sets them up for success. So I think that's one of the many reasons I think that this is really kind of positive.
Yeah, totally agree.
So will these results help me in patient care? You know, Not directly today. And here's why I say that. Like, I don't have the capacity to check in on someone like 6 times per day via televisits. I don't even know if that would actually be reimbursed. And I'm sure that I would get a lot of heat if I had 6 visits from one patient in my office throughout the day. However, I do think that there is a future for this in medicine. We already have this with other services, at least at my healthcare organization, where we partner with third-party organizations that are contracted to manage this type of thing. And I don't know if for example, a single health system would have the infrastructure to build up a program like this for just their own healthcare system. But I could see a third party system in a state or a multi-state telehealth organization that's available that partners with your health system. We currently have that with our behavioral health as adjuncts for counseling with a service called Concert Health, and we also have that for kind of pain reprocessing with a group called Lin Care. And I really really like the way we set up those kind of third party partnerings for these services. So I could see a future where there is a side gig group that does this that we have access to that I could use to kind of get these patients into treatment and then transition them into working with me on a more long-term basis instead of recommending they go to a higher level of care.
It also makes me wonder if some of our local addiction treatment centers that do inpatient, 5-day detox or longer term 30-day treatment, if they would offer this as an alternative, because the problem is, again, the incentives aren't aligned and the money is divided into different buckets. So even with an average of 15 phone calls from a nurse, it's still cheaper than a 5-day inpatient stay at a detox. And you think of one of our local programs, instead of having to go stay there, you could be set up with the home program where they deliver you your meds. You get the 15 phone calls over 3 to 4 days. You get a 30-day prescription at the end of your program, and you follow up with your PCP. It doesn't seem
Yep.
that complicated to organize.
Yeah, one of the docs that's my partners at work, it sits next to me. He's also like a hospice doc, and I could see a setup similar to that, where like you have a nurse or an LPN that's doing this, and they're checking in with the doctor like throughout the day, or they're checking in with the doctor periodically throughout the day, running through the groups of people that they're monitoring. I think there's a way to do this. I think if I ever stop doing primary care, this might be something I explore.
Yeah.
Yeah.
Cool. I think it's a great article. I mean, I think like you, I'm not going to be using it tomorrow in that, because again, I don't have the staff or the bandwidth to do this. Although honestly, I was just thinking, my staff spent like 45 minutes on the phone with a patient arguing about whether his spacer for his inhaler was covered by insurance and trying to figure this out for him. And they could have used that 45 minutes to like detox somebody off alcohol. It's probably all the time it takes, just make a few phone calls, run through the score, see how people are doing. And so our staff does that kind of stuff for people.
Yeah. Maybe.
Maybe.
I feel like my staff gets on those 45-minute phone calls for the patient, and I feel like it's incredibly disruptive because we just don't have to take one of our limited staff members out of the game for an hour for an inhaler,
Yeah, it's true. It was a
I
little
feel like you need a
disruptive.
better staffing model for that. I'm all for something different, but I think in my office flow, we're one-to-one. If I lost my nurse for an hour every day, that would kill me.
Yeah, we're more sort of group to group. We got a lot of staff and a lot of docs. So we have all our residents, so it's a little more chaotic. But anyway, I think it was a great study. I did want to share with our listeners some talkback. We got a comment about episode 69, which was a few weeks ago, about cytisinicline for smoking cessation. And this was from the author of the article, Dr. Rigotti. We had wondered, we kind of mused why this is an old medication. It's generic. It's been available for over 50 years. How come all of a sudden it's now new? And why wasn't it available in the US since it's available in other countries and shown to be effective? And Dr. Rigotti wrote, she said, it's a generic drug. As a generic medication, it would have had to go through the lengthy and expensive FDA approval process to be able to be marketed in the US as a smoking cessation aid. Getting approval for a new medicine costs hundreds of millions of dollars to support all of the preclinical and clinical testing. And any for-profit company that pays that would expect to have a brand protection to recoup the cost. But cytisine, which is another name for the same compound, is already a generic drug. So any other company could then market the generic drug and not pay for the approval. Achieve, which was the company that made the new form, they created a new dosing regimen that is better than the traditional one and got a patent on that dosing. The company which I helped, not I, but Dr. Rigotti helped with trial design and conduct and write up, have no equity in, plans to sell as a branded drug, and for that reason adopted a new name for the drug. And as you said, what they will charge for the drug once approved is a huge question. So that answers that question. We really appreciate you listening to the podcast, Dr. Rigotti, and getting back to us to answer that question we had. So that's it. That's all we have for tonight. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links will be in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman, and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.
Starting a business can seem like a daunting task, unless you have a partner like Shopify. They have the tools you need to start and grow your business, From designing a website to marketing to selling and beyond, Shopify can help with everything you need. There's a reason millions of companies like Mattel, Heinz, and Allbirds continue to trust and use them. With Shopify on your side, turn your big business idea into... Sign up for your $1 per month trial at shopify.com/special offer.